The trial was in adults with head injury who were within 3 hours of the injury, because we saw that in the previous trial that within 3 hours of injury, well, in fact, in this head injury trial, we initially started with 8 hours, within 8 hours of injury, but we changed it to within 3 hours of injury while the trial was going, because we didn't think late treatment would improve outcome. And they could be randomly allocated, they could be enrolled in the trial if they had a very low level of consciousness as a result of their head injury, because these patients bleed into their brain, or if they had a higher level of consciousness but they had bleeding on the CT scan. And the usual consent procedures, then they were randomly allocated to tranexamic acid or placebo. And we randomly allocated nearly 13,000 patients. 6,000 got tranexamic acid, 6,000 got placebo. And randomized trials.
So how can you do the randomized trial on that brain injury? How to allocate?
How do you allocate?
I mean, for the ethical
problem. Well, in fact, there is no ethical problem, because you don't need to collect written informed consent if it's a medical emergency and the patient is unconscious. So a lot of people believe that you must get written informed consent before you can put somebody in a trial. But there are exceptions. And patients who are in an emergency situation, who are unable to give informed consent, are an exception. In fact, it's an exception that's written in the Declaration of Helsinki. And it's a very important exception. Otherwise, we would never be able to find better treatments for patients in emergency situations. So, we have to do clinical trials for patients with heart attacks and strokes and cardiac arrest, and you can't get informed consent, but you can still do trials because you don't need informed consent. So in this trial, patients would have a head injury. They would come to the emergency department. If there was a relative with the patient, we'd ask the relative for permission. If the relative gave permission, we'd put the patient in the trial. But if they were on their own, which is often the case, if an independent doctor said, yes, it's okay to put the patient in the trial, they could be enrolled in the trial without anybody's consent. And we got permission from ethics committees to do that. So, random allocation of big numbers. So, chance and chance alone determines who goes into the two groups. It's a miracle of science, right? You've got to appreciate this. Random allocation is really, I think, just the most incredible invention. Because the challenge of evaluation is to get two groups that are the same apart from the treatment. And if you can get two groups that are the same apart from the treatment, any difference in outcomes, you can say, is due to the treatment. Yeah? And look, these are the baseline characteristics of the patients in the two groups. And this is the severity of head injury, and it's beautifully matched. 38%, 38%, 33%, 33%, 1%, 1%. It's wonderful, right? So usually when you have a clinical trial, people show this table, baseline characteristics, and people don't pay any attention to it. They just want to get to the results. But I think they're marvelous. I think they're really special because they show the power of randomization, especially with large numbers. Now, we did notice while the trial was going that we were getting, this is the Glasgow Coma Scale. That's a measure of how unconscious the patient is. And this is a measure of the pupil reactions. Now, the pupils, they react to light, but if the pressure builds up inside the brain, they stop reacting to light. And that means you're almost dead. it's a very bad sign. It means that there's pressure building up inside the brain and the brain's been squashed. So we were a little bit surprised that we have so many patients with pupils that weren't reacting anymore, because this means that these patients are almost dead. And if you put patients who are almost dead or in a trial, they can't really benefit from the trial treatment, and they just dilute the treatment effect. So we were surprised by this, and so we planned an analysis that excluded patients who had this very bad prognostic sign. And then other baseline characteristics, everything really beautifully matched. So this is good. This is looking good. We've got, a big randomized trial, 2 groups of patients, well matched at baseline.
So how is that this a histogram on the GCS? It's almost about the same, but actually in the clinical situation, it's kind of sort of peak on some GCS number.
Yeah.
Is that why do you?
This isn't really a histogram. All this is showing is that this is the tranexamic acid group, and this is the percent of patients in these different categories. And this is the placebo group. And what I'm trying to show is that they're very well matched. That's all the only point of this slide. Yeah? At the back with a red.
Question about is there any rule for the doctor to allocate the patient? I mean, you talk about randomly allocate, but we saw this result is also randomly allocate. I mean, but how you tell the doctor to allocate?
How do they do it? Yeah, okay, that's a very good question. So the patient, so we have a box, right? So it's a placebo-controlled trial, right? So in the emergency department, there's a box. And in the box has only got a number on. And in the box, there's either, there are some vials, and they're either drug or placebo. And you can't tell. They're just a clear liquid. And so we have we have a bigger box that contains 8 of these smaller boxes. And so when a patient comes in, you just take the first box. The lower, they're numbered boxes, you take the first box and use that for the next patient. And then the second box for the next patient. So the doctor doesn't know, nobody knows what's in the box until the very end of the trial where we crack the code. Yeah? Does that explain it? We used to use telephone randomization, where you telephone a randomization service, and they'll say, you take some characteristics of the patients, and they say, use box number 44. But what we found that in the emergency situation, doctors didn't want to do that. Sometimes they couldn't get an outside line from the hospital. Sometimes they didn't want to pay the cost of the telephone call. So we made it simpler just by taking the next box, and it works very well. Now, in this randomized trial, so what we do is we have a protocol, and then before we crack the code, we write something called a statistical analysis plan. Yeah? We write a statistical analysis plan saying how we're going to analyze the results before we've seen the data, right? Before we've even unblinded the trial. And so we write a statistical analysis plan and we publish it in a journal. And this is to stop data-dependent analyses. So in a big data set, there are lots of associations, and some of them could be chance, but there's a natural tendency to sort of look for these associations and then find them and lift them up. But we try to avoid that by publishing, by saying, look, this is what we're going to analyze, this is how we're going to analyze it in a statistical analysis plan. And so we said the primary outcome is head injury death within 28 days in patients randomized within 3 hours. And then we added this sensitivity analysis that excluded these patients who we thought were practically dead at hospital arrival. So they were they were entered into the trial, but we didn't think they had any potential for benefit. And we thought they were almost dead. And because they're almost dead, you know, we'd have preferred they hadn't been randomized, but they had, and so we planned to exclude them afterwards, because if they've got no potential to benefit, they will just bias the treatment effect towards the null. So, was there any question? No.
For the GCS3, so then you get the Tranexiamic. You check this.
The question is?
So that on that, before the one page before, you showed the patient with the GCS number 3.
Yeah. Ah, yes. Yeah, so if they have a GCS of 3, GCS of 3 and pupils that don't react, that's a really bad sign. Those patients, nearly all of them die. And especially in low and middle income countries, nearly all of them die. And so we were concerned that they were randomized into the trial. And so we said that they've got no potential to benefit, or very little potential to benefit. So we're going to do a sensitivity analysis that takes them out and see its effect on the treatment.
So I think just as a question, also that every patient was taken the computer tomography of the brain after and confirmed the brain injury then, or just only using neurological.
Just for the inclusion criteria, well, if the patient was very bad, if the patient had a low level of consciousness, they could be included in the trial without a CT scan. But patients who had a more mild head injury needed a CT scan and to see blood on the CT scan before they could go into the trial. Yeah? Masafumi, I think you had a hand up.
Yes, thank you. So, the most severe patients will die anyhow. So, why did you include those patients? If they will die due to infection.
It was because we didn't expect that they would be included. I mean, when we were planning the trial, some people said, look, we said we should exclude these patients. And other people said, well, sometimes, you can have a very low GCS because you're drunk, extremely drunk. And so we thought, well, let their doctors use their judgment about who to put in the trial and who to not put in the trial. We said in the inclusion criteria that patients should only be randomized if there's a potential to benefit. And we thought that would cause doctors not to put patients with a very low GCS in because they don't have a potential to benefit. But in actual fact, what happens is when you do a trial, people they don't use much judgment at all, and they just put everybody in who meets the inclusion criteria. So, I think the next slide.